It is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Seven women on my mind. For the one who owned me, two, the one who stoned me once. She's a friend of mine. Take it easy, take it easy. Don't let the sound of your own wheels drive you crazy. Lighten up while you still can. Don't even try to understand. Find a place to make your stand and take it easy. Well, I'm standing on a corner in Winslow, Arizona. It's such a fine sight to see. It's a girl, my lord, in a flatbed Ford, slowing down to take a look at me. Come on, baby, don't say baby. Sweet love is gonna save me. We may lose and we may win, but we will never be here again. So open up, I'm climbing in. So take it easy. Sound of your own wheels make you crazy. Come on, baby, don't say maybe. I gotta know if your sweet love is gonna save me.
Good morning, world. This is Dr. Minarcik from the United States, broadcasting to all you buzzards out there all over the planet. Good morning again. Those were the Eagles, one of the most popular rock groups ever in the United States. And welcome to session number 7 of our online global medical school pathology course. Today is Thursday. It's September 27th. We're in Chicago. And today we will be discussing the second part of what we started 2 days ago, hemodynamics. So today is called Hemodynamics 2. And for those of you who have been on Facebook, you probably saw our announcer, Shazina, make some very cute and funny announcements for our courses. I'm really thrilled with those. When we started this whole thing out a couple of weeks ago, we had 500 registered students. Now we have almost 1,000. I just checked. There's 911. I am so thrilled. I guess it's about time we do our test, although a few of you have already told me that you can see and hear well. I have a little bit of anxiety and insecurity, so we'll ask the question. You know the drill. First question, can you hear me? And I'm seeing a whole bunch of yeses. And the second question is, what do you see? Yeah, everybody sees that really, really colorful fish. I think it's a real fish. I don't think it's photoshopped. I don't know the name of it. I don't know. If anybody knows the name of that species, could it be possibly a wrasse, W-R-A-S-S-E? I'm not sure, but it's just spectacular. So that's why we have it for today. And the test is over with. I don't have too many big announcements. I just wanted to say one announcement today before we get into part 2 of hemodynamics. And it's just a statement about our movies. Movies. I have been making movies for various aspects of histology and pathology for about 5 or 6 years now. Now, the last 3 years, I have made movies of everything that we do here as well. People always ask me about the movies. So let's clarify it. First of all, everything is on YouTube, okay? Under my name, Washington, D.C. Now, the YouTube stuff is not the highest, most exquisite resolution. Oh, it might be okay for those of you who don't know what a slide looks like, but for those of you who appreciate good, fine resolution and histologic quality, we have put the movies also on my website, medicalschoolpathology.com. The problem is, on my website, you may not be able to see them streaming. Now, I have done some tests, and I know that if you have an Android device and a pretty good internet connection, you can see them streaming as soon as you click on them. And also, with the iPhone, there are ways of making them streaming. For example, I downloaded a third-party program for the iPhone called Azul, A-Z-U-L, and that makes them stream also. There's even ways of making them stream with Macs and with PCs, but it's usually not that easy. For example, with a PC, you might have to download a third-party software called DivX, D-I-V-X. It's also free. So just remember, movies are abundant, and the reason why I'm telling you this is, you know, I'm not trying to get rid of you because I like you, but the movies that we have made this year and last year, which are on my website, they are actually better quality than what you are seeing and hearing when you come to the live recording sessions. But I appreciate you at the live recording sessions because your constant little comments into the chat boxes really give me tremendous feedback that I need. Plus, I know it's fun. And I also know that it's more fun to be in the lab than listen to a lecture. So today we're going to do both. So here we go. We're going to pop out the window and we're going to show you our lecture on the left, and we're going to show you our lab on the right. You can see we have about 9 cases for lab today. And we've already covered a very good large portion of the lecture material on hemodynamic disorders. So I think, guess what? Just by coincidence, I happened to get the right place where we left off. You can see the slider bar here is about 2/3 of the way down, so we're on slide 69 of 113. I know when I go to boring lectures, I always like to know what number we are on PowerPoint so I could expect it to be over, you know, without much more agony. So, let's broaden this window. And if you remember, the very last thing we talked about before this particular slide was the hypercoagulable states. And if you remember, we talked about the common inherited or genetic reasons for having a hypercoagulable state. And then we flash the old coagulation diagram in front of you again. You know, and I hate to be sadistic, but you must memorize this, every single aspect. We're going to throw this at you 5 or 6 times during the course, and there are maybe other diagrams that you like that look better, but this is the best one I could find, and I looked for a long time. And then we talked about the common acquired hypercoagulable states, some of being higher risk, and a few common things here like smoking, obesity, birth control pills being some of the lower risk ones. Okay, so here we are. We're into the good stuff now. We're going to talk about the morphology of thrombi. Okay, well, the main thing to remember about a thrombus, and if it doesn't adhere, it's not really a thrombus, because if it's a clot and it doesn't adhere, it's probably going downstream, either towards the heart if it's in the vein, or away from the heart if it's in an artery. So thrombi adhere, okay? When they adhere to the chamber of a heart, like a ventricle or like an atrium, atrial mural thrombi are very, very, very common with atrial fibrillation, simply because there is no uniform contraction of the muscle and the flow is very, very turbulent, having many eddies. Mural thrombi are also common after infarcts, in which the surface, the endothelial surface of the heart, is damaged, sets up the setting for a thrombus. The arterial thrombi, okay, most of them are from the heart, but a good number are from the aorta, could be very, very occlusive and cause an infarct to that area. That makes sense. An occlusive arterial thrombus will infarct unless there is collateral or a secondary circulation system. The venous thrombi, by definition, adhere to the vein, and if they do break off, they form emboli. Okay, and there's only one place they could go, and that's the lungs. Now, thrombi can then obstruct the total lumen of the vessel, in which case it may cause an infarct, or it may not obstruct. It just may grow. It just may interfere with the flow to that particular organ. Perhaps not enough to cause an infarct. Okay, but even a non-obstructive significant thrombus in an compromised patient, for example, somebody with congestive heart failure, may infarct as well. And amazingly, a very large number of people with myocardial infarcts, classical destruction of the wall, either early, recent, or late, will not, very frequently will not show obstructive infarcts, okay? Now, if you remember, when we talked about aging of inflammation or aging of tissue that's been necrotic, or this whole inflammatory process, generally speaking, a recent thrombi is red, simply because it's mostly red cells. Sometime in the several days to perhaps weeks after that red clot, it may become yellow, simply because of the ingrowth of macrophages chewing up junk, including fats, as well as blood vessels. With time, this clot will then become firmer and grayer, simply because it is chiefly fibrous tissue. So, red thrombi are recent. We're generally talking days, probably not much more than weeks. The natural evolution would then cause them to be yellow. And remember also that this also has a lot to do with the aging of the blood pigment as well. We talked about looking at the different chemical changes from hemoglobin to bilirubin compounds all the way to hemosiderin. And of course the old or the healed or the remote, and these are usually months to years, thrombi are gray or white. So these three concepts here in bullet point number 3 correspond to the adjectives down here. A red thrombus is probably acute, a yellow thrombus, and remember, this is to your naked eye, this is not under the microscope. A yellow thrombus is we might call organizing, and a grayish white one, which is chiefly scar tissue, can be called old. And remember, not only do these aging factors take place in the actual thrombus, but they may very easily take place in the tissue in which they may infarct as well. Remember, we saw that picture in lab the other day of a thrombus in a coronary artery, as well as the changes in the myocardium, all undergoing the same general evolution. Okay, so here we go. Here is a left ventricle here. I think that is pretty easy to figure out. You can see a pretty thick septum here. You can see the lateral wall. You could see the mitral valve, and you can see something that looks like it's adherent to the endothelial surface. That's a myothrombus, okay? Most likely it formed there because of an infarction of the underlying area. I guess technically it could be there for other reasons. For example, if there was a venous thrombus and a left to right shunt in the heart, you could technically get one there. Those are extremely rare. I've only seen one or two in my life. And it looks like that some of that thrombus, that mural thrombus, may affect the right ventricle as well. And you see the white area underneath it. You almost know that if you put that under the microscope, that's going to be scar tissue. So this mural thrombus, when you can see increased scar tissue here as well, probably has formed in the setting of a healed or old infarct. And remember, just as though the tissue in the myocardium is undergoing those changes from recent to organizing to old, so is the thrombus. This is an opened up aorta, okay? And I don't think you can see the thrombus as well because there's a lot of junk in there, but I suspect that this area here is a good sized thrombus in the aorta. And remember, arterial thrombi, probably I should have put an 80 in front of the myocardium because about 80% come from the heart and about 20% come from the aorta. Now, there's only 5 things that I could think of that thrombi can do. I guess if you thought of a 6th one, that might qualify you for a Nobel Prize. The first thing they could do is propagate. And when a thrombus grows inside of an area in which it has formed, it generally propagates downstream. So if it's in a vein, it propagates towards the heart. If it's in an artery, it propagates away from the heart. It propagates in the same direction it embolizes. And that comes to our next possibility, embolization. An embolism goes downstream. I mean, I don't think you have to be a rocket scientist to figure it out. It has to go with the flow. One thing that it does is heal, or dissolution of an emboli normally would occur, and hopefully would occur in most cases. And in that case, the thrombus eventually just dissolves, the fibrin inside of it gets weakened, the tissue becomes apoptotic, it gets cleaned up, and it's not there anymore. And that would ideally be the outcome of thrombi, but very often isn't. And of course, we also know that the thrombi can organize just like any inflamed or infarcted tissue can organize. And organization means ingrowth of new blood vessels, perhaps a lot of chewing up of the junk with macrophages, and of course eventually fibrosis. But the fibrosis is not part of organization. Another interesting concept which occurs frequently is the concept of recanalization. And recanalization is this. It means you have a thrombus that has occluded a vessel, or almost occluded a vessel. Well, eventually, possibly because of pressure or reasons only, you can have a new endothelial surface growing inside of that thrombus and going through it. It's like putting a plug on top of into a pipe, but then you drill a little hole into the plug. So that's the concept of recanalization. And whenever you see a thrombus, especially an older thrombus, not recent, usually organized or old, because this process takes a while, and it looks like that there is an endothelial surface, or at least a hole in the middle of it, that's probably recanalized. So here's the fate, again, only now more graphically. Here's your thrombus. It propagates towards the heart if it's venous. It propagates away from the heart if it's arterial. But this is a vein because it has a nice thin wall, because they are telling you it's an iliac vein. If it resolves, it's completely gone after a period of time. If it embolizes, anatomically speaking, there's only one place it could rest, and that's the lungs. If it becomes organized, it could actually go through the changes that we talked about, with ingrowth of blood vessels, followed very quickly by ingrowth of fibroblasts. And finally, the recanalization concept is that even though it may have occluded or almost occluded, there are still vascular channels within it, lined by endothelial cells. You may not see them. They may be very, very thin. And so now we have, I guess you could call it a detour, but it's going through the occluded area. So even though the thing is blocked, the blood rushes through anyway. Here's another example of a thrombus. This is no longer a diagram. This is a real H&E picture. And first of all, I think you could appreciate this as being some kind of blood vessels, because you see spindly, smooth muscle-looking cells. The problem is it doesn't have a lumen. But if you do know this is and there's a good amount of smooth muscle here too. It's pretty thick. So you could probably think this is an artery or small artery, and you could probably imagine that its vessels completely occluded. Now, why did they do the elastic stain? Well, they did the elastic stain simply because, number one, they wanted to point out the fact this is an artery rather than a vein, because just from looking at these sort of disrupted smooth muscle bundles, even a pro might get fooled, but it's so thick you probably didn't think it's an artery anyway. So there is your internal elastic lamina, which of course veins don't have, and it also may be disrupted a little bit as well, simply because the entire lumen now, which is not open, has an organizing blood clot. And you know it's not recent because it's not totally red cells. And you know it's probably not that old either, simply because, I don't know, I don't think I could convince you that the majority of these cells are fibroblasts. The majority of them are macrophages. So and maybe some new blood vessels. So we know we're in the organization phase here. That would be a good question, but I've already answered it, so let's move on. Now, let's go into the thrombosis of what we call the deep veins, or deep vein thrombosis. And by deep veins, they don't just mean any deep vein. They're usually talking about, when you hear the term DVT, the deep veins of the pelvis and the deep veins of the lower extremity. So, deep vein thrombosis occurs in the calf, the thigh, and the pelvis, okay? The reason why DVT has to be singled out is because the vast majority of pulmonary emboli, especially the clinically significant and the clinically apparent pulmonary emboli, occur with deep vein thrombosis. You know, if you have a patient that has a deep vein thrombosis of an arm, you probably don't have to worry too much about a pulmonary embolism. If you have one that has a swollen leg, or a venogram or some other radiologic method shows thrombosis in the deep veins of the pelvis or lower extremities, then that is at risk for pulmonary embolization. Of course, congestive heart failure is a huge factor, simply because a person with congestive heart failure does not have the greatest amount of flow anywhere in the whole system, including in the deep veins. It's also a factor for inactivity as well. Most of the patients that have a PA have it from deep vein thrombosis, and most of those patients are chronically ill, hospitalized patients, people that maybe have not got out of bed for days or weeks or longer. So that's the setting for a deep vein thrombosis and a pulmonary embolism. And I speak about the two identically because pulmonary emboli are caused by deep vein thrombosis 90-something% of the time from the calf and the pelvis. Trauma is a factor, especially trauma to the endothelium, of a deep vein, for example, surgery, or perhaps a leg injury, for example. Burns are included in that category. And the bottom line for any thrombosis, including deep vein, would be injury to the endothelium of the vessels. Okay, the same thing that we saw in the last class. Now, could procoagulant substances from the tissues, hypercoagulable states cause it? Of course they can. And last but not least, if you have a substance called tissue plasminogen activator, and for some reason it's reduced either genetically or because of an acquired reason, then that would interfere with your normal state of constant hemostasis or dissolution of clots, and therefore it would be a factor for DVT and therefore pulmonary embolism. Now, let's talk about thrombi in the arterial side. First of all, as you know, I should not precede a lot of these statements with "as you know." Almost all, or the majority of significant transmural myocardial infarcts are not just from old, severe atherosclerosis. In almost every case, there's a fresh thrombosis superimposed on old atherosclerosis. We're going to go into this in great detail in the heart and blood vessel chapter. So, first of all, a thrombus of a coronary vessel occurring on an old atherosclerosis is the number one cause of acute myocardial infarction. You could probably think of a few other reasons, for example, like primary inflammation of the arteries. Now, the arterial thrombi go downstream or away from the heart, and in contrast to the venous thrombi, which are embolizing or propagating, they go in the opposite direction. Now, when they propagate, because that fresh thrombosis is intimately mixed up with old, perhaps calcified plaque material in atherosclerosis, an arterial thrombus may very well have flecks of calcium or cholesterol as well. So that's really a cool question, isn't it? What's the difference between an arterial thrombus and a venous thrombus? If you just pull it out of the body, put it under a microscope, if you see calcified material in there, or cholesterol clefts or plaque material, then you know it's arterial. Now, very often, you'll go to a conference and they'll say, well, 15% of the arterial emboli go to the brain. And then you'll go to another conference and they'll say 25% of the arterial emboli go to the kidney. It's very simple. Where it happens to lodge after it breaks off, if the thrombus does break off, is directly proportional to the percentage of cardiac output that organ receives. I think I did write a diagram there somewhere. But basically, if the spleen gets about, 5% of the cardiac output, then 5% of them go there. The kidneys classically get about 20 to 25% of the cardiac output, and the brain gets about 15%, and even though it's 15% of the output, it might be only like 3% of the total body weight. So organs like kidneys and brain get a whole hell of a lot more blood than they should on the basis of its size. So here's an arterial emboli, and I think we're going to have a case like this in the lab either today or in another day. When you see a vessel that's thrombosed and you can clearly see cholesterol clefts within it, you know that this is not probably not a primary thrombosis of a small vessel, because small arterial vessels don't get that much calcium and cholesterol in them. They usually come from higher areas. So anyway, anytime you see a thrombosis of a vessel and you see these little cholesterol clefts, think that it probably embolized 80% likelihood from the heart, 20% likelihood from the aorta. Okay, DIC. This is one of our last topics because it fits in hand with the concept of shock. Both shock and DIC are joined at the hip. We've already mentioned it We'll say it again. What is DIC? Well, it stands for disseminated intravascular coagulation. Sometimes you hear the word disseminated intravascular clotting. Okay? Now, DIC almost never occurs simply by itself. It occurs in the arena of patients that are very, very, very ill. Shock usually precedes DIC and goes with it. Okay, patients that are having very, very, very difficult time having babies, a lot of obstetric complications, or DIC is the greatest fear of a regular OB doctor, because when that happens, often they know their patients are in very, very deep trouble. Also, DIC occurs very often in very, very sick patients with advanced malignancy. So it's not a primary disease. Now, when you have diffuse coagulation going on inside of small blood vessels, okay, by intravascular, it's primarily at the capillary level. What happens? Well, you're consuming all of your consumable coagulation factors. So, are platelets consumable coagulation factor? Yes. Is fibrinogen a consumable coagulation factor? Yes. Factor 8 is classically very, very consumable as well. It means if you use a lot of it, it's going to be low. Okay, that's what consumable means. So, if you look at patients that have DIC and you're seeing these small thrombi in either the capillaries of the lungs, kidneys, or technically speaking anywhere else, and remember they're microscopic findings because they're extremely small vessels, you are then going to have decreases of these other factors like platelets and fibrinogen and factor 8. So it complicates the matter even more, because not only are you clotting in the small vessels, but you're using up so much of these factors, you are then bleeding in other places. And the OB docs will tell you that when they have had patients that have developed DIC, that they might have to have given them like 10, 20, 30 units of fresh frozen plasma or other substances which have a lot of the consumable coagulation factors. Okay. Here's a classical example of a DIC, and I must admit, if you have not seen a gazillion glomeruli, I think you already all know that this is a kidney. Okay, that part I'm not concerned about. You can see the proximal tubules around it. But what you might not appreciate like instantly is that there is a lot of eosinophilic granular or hyaline-like substance plastered or situated in these glomeruli. There's a lot of material there, there's a lot of material there, and that's fibrin. And if you had any doubt about it, there are plenty of stains that will identify fibrin. There's some fibrin there, there's a lot of little fibrin loops there. And what does that mean? It means that this patient is forming clots inside of the glomerular capillaries. And that means that there's a good chance this patient has DIC. There's a good chance it's in many, many, many glomerular capillaries. There's a good chance it's in brain, it's in liver, and it's everywhere else in the body. This patient is in very big trouble. So that's technically DIC. And what we're going to do at the end is talk about shock, and we're going to show you how DIC goes hand in hand with shock. In fact, technically speaking, each is not only an effect of the other, but each causes the other. Okay, what I'm going to do now is try to turn off whoever is making that extraneous noise. I know you may hear a little bit of noise in the background, and I'm going to look at my attendee list here for a second, and I'm going to see Dr. Girish Kamat has a little bit of noise in the background, so I'm going to mute him. Girish, if you could hear me, you should probably not make noise or unplug your microphone, because I'm having a hard time muting you. There's even a way you can mute yourself. Oh, here we go. I think I just muted you now. Okay, noise is gone. By the way, folks, did you just hear the noise disappear? Oops, there's still a little bit there, isn't there? Well, we got rid of most of it. Okay, if any of you are talking to Dr. Kamat on chat boxes, and I'm sure a lot of you are, please remind him to mute his microphone or unplug it if he doesn't know how to mute it. Embolism technically is a breaking off of a thrombus from either an artery or a vessel. And it may not even be a thrombus. It could be a piece of fat. It could be air. It could even be amniotic fluid. These are things that have occurred before the word embolism is either fat, air, or amniotic fluid. The classical embolism, the one that you will be dealing with, the one that you will be fearing if you're a surgeon or having to treat if you're an internist in chronically ill patients, are pulmonary emboli. So often the word embolism is understood as pulmonary embolism until proven otherwise. Now, you can also have a systemic embolism as well, and that would be not from the venous circulation, but from the arterial circulation. We're going to give you a few examples of things that could embolize other than thrombi, like fat, air, and amniotic fluid. In fact, we're going to go into this in more detail in the environmental exposure section, but let's just have the concept nailed down. Now, the thing that most people don't believe or don't know, but you should know, is that most pulmonary emboli are silent. Okay? Most pulmonary emboli are silent. They're asymptomatic. You don't even know you have them. Those are usually small ones, okay? Now, when they are not silent, when they show clinical signs and symptoms, the most common symptom is chest pain. Okay, in the lab, the most reliable index in the lab is a low PO2. Hand in hand with the chest pain is often acute shortness of breath as well. These are usually significant emboli, and if they are significant enough to occlude over 60% of the pulmonary vasculature, which means at least one whole lung and maybe more, then that's very, very risk for not only sudden death, but acute heart failure, simply because that right heart cannot pump blood into that massive organ that it's supposed to pump blood into. Now, you'll also hear the concept of a saddle embolism, and you know, a saddle basically flops on both sides of the horse, doesn't it? So you can have a blood clot that flops from the main pulmonary artery into both main right and left pulmonary artery, and it occludes most of it. Okay, well, saddle emboli are very often the most feared because they are technically have a very high likelihood of being fatal. Okay, and also remember, from not only the pathologist point of view, but also from a very important medical legal point of view, it's very important to determine whether that blood clot that's in the lungs clotted before or after the patient died. Now, for those of you, in fact, I'm going to do a survey right now because this is important. I need to know how many of you all have dissected cadavers. Well, I'm seeing a whole bunch of opinions saying yes, yes, yes. I expect most of you should have because, you know, pathology is a second-year course. Well, for those of you who have dissected cadavers, you probably remember that you may have found very, very hard blood clots inside of the vena cava, inside of the heart. And maybe the patient was fixed with formalin or more likely embalming fluid by the time you did that. And those clots can get very hard. And sometimes they're so hard you think that they formed before the patient died. But it's very important to say whether that clot formed before the patient died, and it means it may have been what killed them as well, or whether it formed after the patient died, which means it's just settled, hardened blood, perhaps hardened even more by the various fixatives that are used. Now, the premortem blood clots adhere to the blood vessel wall. Okay, even if that blood clot is as hard as a rock, it's probably going to peel off very, very easily from the wall of the vessel. You remember that? So adherence is the main concept of a premortem blood clot. Another thing is a premortem blood clot, even in the early stages, even within hours perhaps, starts to form with influx of inflammatory cells, with deposition of fibrin. So you see microscopically what they call lines of Zahn, Z-A-H-N, that correspond to those premortem changes. Postmortem blood clots don't form lines of Zahn because the patient's dead, and it means the cells are dead and there's no production of fibrin after you die. A postmortem blood clot is less likely to be friable or crumbly. It's more likely to have a non-texture, and the two things that they compare it to are currant jelly and chicken fat. So for those of you who have not seen currant jelly, that's currant jelly. It looks like regular jelly to me, maybe a little softer than usual. And there's chicken fat. That's not a blood clot. That's an actual piece of chicken fat. And if you've seen chicken fat, it doesn't really have a texture. So the two on the bottom are post-mortem blood clot textures, either red or yellow. Now look at this clot up here inside this big vein. To tell you the truth, I don't know exactly what this vein is. I don't think the photograph is good enough. But if this blood clot adheres to the wall and it doesn't just peel off very easily, no matter how hard or how soft it is or what color it is, it's almost certainly a premortem blood clot, because post-mortem blood clots don't adhere. Currant jelly and chicken fat, you could just swipe that off the inside of the vessel. And take a look at this microscopic picture of a blood clot now. I'm going to ask you, with your great experience, when you look at that microscopic picture there, is that a pre or is that a post-mortem blood clot? I need the answer. Yeah, it's post, because you can already start to see lines of cells coming in and also deposition of fibrin. If it was just a regular old blood settling, it wouldn't settle with having cells nicely and linearly interspersed with fibrin and other cells. So that's the line of Zahn. Okay. Have any of you ever ridden a horse? You know you have to put on the saddle, right? So there's the saddle. Here's the main pulmonary artery, and this huge blood clot, no doubt from either a deep pelvic vein or a deep leg vein, has lodged, and it's been so big it flipped over both sides. And that's why we're looking at this thing at autopsy, because theoretically, if you obstruct acutely more than 60% of your pulmonary vasculature, you're probably going to die very, very quickly. Now, just as an anecdote, I can tell you I performed, thousands of lung scans during my long career, and we would look to see in nuclear medicine, how much of a lung was occluded. We would do these scans, and we would label the pulmonary vasculature with isotopes, and sometimes you could even see like a whole lobe of a lung. Let's say that could be anywhere from 20 to 30% of your entire lung field. Occlude an entire lobe of a lung, like a right middle lobe, for example. And very often the patient has minimal symptoms. Okay, they may have a low PO2, they may have a total non-perfusing lung on CT or pulmonary arteriogram or lung scan, but they may not have the clinical symptoms of acute chest pain and shortness of breath. What about the arterial or systemic emboli? Well, they form in the arteries, don't they? Now, there is a concept of a paradoxical embolism, and the reason why it's called paradoxical is because the thrombus forms in the vein, but it winds up being in the systemic circulation. Now, how is that anatomically possible? Well, it's only anatomically possible is if there's a left to right shunt. A right to left shunt, and there's a defect somewhere in the heart, either at the atrial or ventricular level. These are very, very common, but it would be a nice question for some self-righteous guy to say to you, how could a clot in a renal artery have come from a vein in the pelvis. That's the only possible way, is if there's a right to left shunt. Like I say, most of them are cardiac, but a good number are from the aorta. And once again, we got your little diagram here. The embolization, or where the systemic emboli lodge, is in direct proportion to what percentage of the cardiac output that organ gets. Now, last night I looked up the fact that the brain technically gets about 15%, the kidneys about 25, an amazing amount. For as small as the kidneys are, only 150 grams each, they can get as much as, let's say, 20 to 25%. There's a lot of blood flow going to the kidneys. Your splanchnic circulation can get as much as 25, but in a non-prandial state or a exercise state, it may be a lot less than that. Amazingly, the liver can get up to about 25% as well. The thing is, the liver is not likely to infarct if the hepatic artery has a large embolism, simply because the liver has a dual circulation. True infarcts of the liver are very, very rare. You know, and I know what you're thinking. You're thinking, well, what about emboli that go to the lung? Shouldn't they cause an infarct? Well, most of the time, they absolutely do not, for the same reason that the liver doesn't infarct, and that's because they have a dual circulation as well. Remember, the majority of the blood going into the lung is from the pulmonary artery, but there's a good amount that comes from the bronchial artery, and that's why most pulmonary emboli, in which there is non-ventilation, perhaps of an entire lobe, or perhaps an entire lung, are not going to infarct, unless the bronchial circulation is also compromised. You know what? That's very important, so I'm going to say it again. Most occluding emboli do not infarct. In fact, that's the basis of lung scanning, and it's also the reason for the classical V-Q mismatch, because V is ventilation and Q is flow. So you can have zero flow in a significant portion of the lung, or zero Q, but you can still have good ventilation because it's not infarcted. So that's a classical V-Q mismatch, and that's what's present in pulmonary emboli. Now you can have other mismatches for other reasons, but that's the classical one. Now, we talked about blood clots so much, it wouldn't be fair if we didn't mention also emboli from other things besides blood clots. You can have fat embolizing, through blood vessels, particularly veins, and very often with fractures of either long bones or other bones, some of that fat and even the marrow, if it's can get trapped in those venous sinuses and wind up embolizing to the lungs. Sometimes this can be demonstrated by seeing fat in the pulmonary arterial vessels and smaller vessels, but very often it's really very hard to find. The thing that's really hard to diagnose is an air embolism. So unless you open up the lungs underwater, you're not likely to see a bubble coming out. But air embolism also is responsible for other symptoms that deep sea divers, scuba divers get, like what they call the bends and the chokes, and we're going to be dealing with that in greater detail later. So, but just remember, besides blood clots, fat, air, and amniotic fluid can also embolize, and they are chiefly venous emboli. Another type of embolism is amniotic fluid, and not only do very prolonged or difficult deliveries result in a DIC, but they can also result in amniotic fluid embolism, which has a very, very high mortality. In the case of an amniotic fluid embolism, you might actually see a small pulmonary blood vessel, and there's some red cells engorging septae. And you see these little linear or laminated flecks of tissue within these small pulmonary arterial vessels, and you know what those are. Those are squamous. Those are the same cells that line the amniotic sac. So demonstration of squames in a pulmonary arterial blood vessel is absolute proof of an amniotic fluid embolism, because not only does the fluid go in there, but also the squames that line that fluid in the amniotic sac. Here's an interesting thing. If I was here, you know what? You're probably going to figure out what this little trick is. But let's say that you were having an exam and somebody just asked you, what kind of tissue is this? Well, you would say, well, it looks like half of it is fat. It looks like there's a mixture of different types of cells. Perhaps some of those cells are real big. So you're going to say, yeah, that's bone marrow. Okay, good. Well, then they're going to put the rest of the picture into place, and they're going to say, yeah, you're right. This is normal bone marrow and fat. The problem is, it's inside of a blood vessel. So this is an example of a fat embolism. And very often, fat emboli do not really demonstrate that well. You may have to look very hard, but when there's marrow inside of it, you know. Now, here's another interesting question. Did this fat embolism come from a crush injury to the chest, a significant fracture to the femur, or a significant fracture to the humerus? Where did it come from? Well, no. For those of you that are saying femurs, or absolutely not, you want to know why? Because if you remember, in adults, there is no bone marrow in the long bones. Okay, there's only fatty bone marrow. So if you have hematopoietic bone marrow, it probably resulted from a fracture of a bone that is in the axial skeleton and not the appendicular skeleton. Well, what is the natural consequence of embolization and thrombosis? And there's your answer. It's infarction. If tissues don't get oxygen, they don't get blood, they don't get glucose, they're going to die. And infarction is defined as necrotic tissue secondary to a decrease in blood flow. And they can also have the term hemorrhagic or anemic put in front of them too. That means basically either red or white. And in organs that have a dual blood supply, like the lung, for example, infarcts can look very hemorrhagic. In organs that have end arteries, classically spleen, classically kidney, that's not going to be a hemorrhagic infarct because there's no secondary blood supply. It's going to look very white. It's going to look very pale in the early stages. So sometimes the word red and white are used as well. And the red infarcts are in organs which have dual blood supply. White infarcts have end arteries. And I also told you that there is very, very rare to see a true infarct of the liver. But if you do, it's probably going to be a red infarct, wouldn't it? Because, you have your significant secondary blood supply. Not only does the portal vein supply, 75–80% of the liver, but you got a big whopping 20% or so, or 15, let's say, coming from the hepatic artery as well. And just like the clots themselves, whether they're thrombi, whether they're emboli, they also have an evolution of colors and an evolution of changes, and follows the same pattern that we've seen in all of discussions on inflammation and healing and organization. The infarcted tissue itself can show acute stages, perhaps necrotic tissue, perhaps influx of leukocytes. The organization is characterized mainly by blood vessels growing in, perhaps some macrophages still chewing up the junk because there's overlap. But in the early part of the organization phase, even the fibroblasts come in. And of course, in the healed stage, fibrosis, it's basically white. So isn't that amazing? We see the same type of evolution of changes, not only in the clots, but in the infarcts that they cause. I think that's just spectacular. Now, what are some of the factors for infarcts? Well, once again, if something has a dual blood supply, it's less likely to infarct. That's obvious. Now, if an infarct develops very, very quickly, that's really bad, because it means that patient is going to have significant acute symptoms and a disease. If very often infarcts develop very, very slowly, and that would technically be better, simply because the tissue that it feeds has already been adapting to the slow cutoff in oxygen, and the tissue may have already started to have some ingrowth of new blood vessels. So an acute infarct is much worse than a chronic or slow infarct. And remember the cells themselves. You remember cells like cardiac muscle and skeletal muscle, and especially neurons. You know, they have a tremendous need, a tremendous desire for a lot of oxygen. Whereas cells that really aren't that important, like, you know, fibroblasts and fat cells, you know, they'll have a less of a vulnerability to hypoxia. And of course, it's also very logical to think that somebody that has congestive heart failure and not enough good general flow to begin with is going to do a lot worse than somebody that doesn't have congestive heart failure. Here's a hemorrhagic infarct, it's in the lung, and here's a white infarct in the spleen. So that's a red infarct, it has a dual blood supply, it's hemorrhagic. Here's a white infarct, it's in the spleen. Remember, the spleen has end arteries. There's no secondary dual blood supply. The thing that you also have to remember from this picture is the reason why pathologists frequently put on a blindfold during autopsies, and they just start feeling the peripheral pleural reflected surfaces of the lung, because you're very, very likely to find an infarct by just looking at these peripheral pleural surfaces, because almost all of the infarcts of the lung, even though they're rare, they occur, number one, with emboli, and number two, with impaired bronchial circulation, but they always appear at the very periphery of the lung lobe. It's not likely to get an infarct near the hilum of the lung, and everything else beyond that is normal. They're always at the peripheral pleural reflection. So that would be a nice thing. We said that we can diagnose cirrhosis with a blindfold. We can also diagnose pulmonary infarcts wearing a blindfold as well. And this is an anemic infarct, you know, and you know they're both in the fairly acute stages. You know, this thing may resolve, or it may undergo organization and fibrosis technically. In the lung, it's more likely to resolve. And here's something that's called an anemic infarct, and it is very likely to undergo organization and then fibrosis as well, heal with the scar. Same thing with the kidney. And speaking of kidneys, you know this is a normal kidney. You know that there is a regional area, a significant regional area in the middle of this kidney in which there is absence of cortical substance, perhaps replacement by either scar tissue, or you're not sure. Here is perhaps the same area, and whereas you can see glomeruli and tubules at the top of this field and not so much on the bottom, in this area you don't see much of anything except coagulation necrosis. So that means it's necrotic. That means it's infarcted. And in the kidney, the infarcts are usually pretty well delineated. Look, they often talk about wedge-shaped infarcts in kidneys. Well, that's extremely wedge-shaped, isn't it? In fact, I would probably guess that if you were really good at your anatomy, you could probably give me the name of the segmental artery, or perhaps primary branch of the main renal artery, that has caused that infarct. And look how well delineated it is too. Not only grossly on the picture here, but also microscopically. That's still pretty good delineation, isn't it? Heart. We've been skirting around it. There's a heart. There is a bread loaf or axial section through the left ventricle mostly. That might be a little rim of right ventricle there. I'm not too sure. Which means this would be the septum, and that would be the lateral wall. Well, you can see it's mottled, it's discolored, and I know what you're thinking. You're thinking, well, is that white stuff perhaps necrotic heart, or is that white stuff fibrous tissue. Maybe it's a scar from, 10 years ago. So you do the microscopy of this mottled white area and you see this. You see absence of nuclei, or karyorrhexis, and you see infiltration of neutrophils. So the answer to the question, is this whitish mottled area here acute, organizing, or old? You put it under the microscope, and what's your answer? Acute, organizing, or old. You know it's all acute, don't you? Because you have necrotic tissue, infiltration by neutrophils, and absence of nuclei. Those are all classical changes in the heart of an acute infarct. Okay, we're down to our very last topic, and it's not that long. And I think we'll do it after our break. And also after our break, we're going to take these, 9 cases and go to lab as well. I know lab is a lot of fun. So what we're going to do now is do our music. And by the way, today, I picked out all the music today, and it comes from my 4 favorite types of music. Not only do we hear classic rock with the Eagles, but during the break we're going to hear country, we're going to hear Motown, and we're going to hear hip-hop, and they all rock, and those are my favorite kinds of music. So we will see you in 10 minutes after we hear from Randy Travis, Aretha Franklin, and Rihanna. See you in 10.
This love that I feel for you always will be. But you're not just time that I'm killing. I'm no longer one of those guys. As sure as I live, this love that I give is gonna be yours until the day that I die. Oh baby, I'm gonna love you forever, forever and ever, amen. As long as old men sit and talk about the weather, as long as old women sit and talk about old men, if you wonder how long I'll be faithful, I'll be happy to tell you again. I'm gonna love you forever and ever, forever and ever, amen. They say time takes its toll on the body, makes the young girl's brown hair turn gray. But honey, I don't care, I ain't in love with your hair. And if it all fell out, well, I'd love you anyway. They say time can play tricks on memory, make people forget things they knew. But it's easy to see, it's happening to me. I've already forgotten every woman but you. Oh darling, I'm gonna love you forever, forever and ever, amen. As long as old men sit and talk about the weather, as long as old women sit and talk about old men, if you wonder how long I'll be faithful, well, just listen to how this song ends. I'm gonna love you forever and ever, forever and ever, amen. I'm gonna love
Welcome to GoToWebinar, Web Events Made Easy. Welcome to the webinar. You have entered as an organizer and may now speak to any other organizers or panelists on the line.
Jim, are you on a webinar right now? You just knocked me off. You just knocked me off of my webinar, Jim. I was in the middle of the break. It's no big thing. If you could end your webinar now for at least 1 more hour, I'll be able to finish my class. Okay, remember, I'm on every Tuesday and Thursday from 9 to 11. Okay, bye-bye. End it now. Bye-bye.
Welcome to GoToWebinar, Web Events Made Easy. Welcome to the webinar. You have entered as an organizer and may now speak to any other organizers or panelists on the line. When you are ready to begin the presentation, press the Start Broadcast button on the GoToWebinar control panel to allow all attendees to hear you. This system will notify you once you begin your broadcast.
Hello, everybody. Are you still there? It looks like we had a temporary problem here, but I think we're back. Or I could see most of you are back anyway. I know you could hear me. In fact, what happened? Somebody wants to know what happened. I'll tell you what happened after we play our last song. But we are back in business. Well, folks, I know you could hear me, and we are back, and we'll do the test anyway. Can you all hear me? That's the first question. I know you can. Yes, yes, yes. Second question is, what do you see on your screen again? Okay, the fish. Good. We had a nice break. In fact, we had too much of a nice break because somewhere in the middle of the first song, we got cut off. And you want to know what happened? If you look at your list over there, it looks like my name is Jim Lou. I am not Jim Lou. I have never been Jim Lou. Jim Lou is my boss. Jim Lou is the founder of GoPath. I use his name and login number and password to get into the webinars. Okay, now he just happened to be starting another webinar while I was doing this webinar, and therefore we got bumped out. Now, did you hear the beginning at least of the first song, Randy Travis? Yeah. Well, somewhere in the middle, Randy got bumped because Jim was overriding us. So I called Jim on my cell phone and I said, Jim, you have just kicked us out of our webinar after the first hour. So he quit his webinar and I'm back in business again. And I can see most of you are back here again. If some of you freaked out and thought that Chicago was hit by a nuclear bomb, it wasn't, folks. It was just a glitch because the webinar people won't let Jim in at 2 webinars simultaneously. Okay, we're back. And might as well ask you, was the first half, did everybody hear okay? The first half? Okay, good. And I also want to let you know that Dr. Kamat is also back, so keep up your questions. I imagine he's been very busy because I saw there were a lot of questions that you were asking him. And I also want to remind Dr. Kamat to either unplug his microphone or make sure he's muted because we were hearing a few noises until he muted himself. But now everything is perfect. Okay, we're back. We got to hear 2 songs. We didn't get to hear all 3. The third song by Rihanna was interrupted during the break. The only thought I got during the break before this fiasco occurred is that, you know, when we go through these various chapters, we have feelings about how well they're going to go based on how well they went before and how well we know the material. For example, this is my favorite chapter, and I often had a little bit of fear and hesitation for the next chapter we'll be dealing with next week on genetics, only because it's very complex. It's complex for me to understand too, but over the years I have decaffeinated genetics, and last year I actually enjoyed it. So I want to just tell you something. The greatest, even though I believe that learning should be a joy, and of course teaching is a joy as well, the greatest, I wish I shouldn't say necessary, one of the great motivating factors is fear. So if you've ever had a dream that you were called up to go to the front of class and you didn't know a damn thing, believe me, I have those nightmares too. And before every single session, I have fear that I'm going to be sitting here and I'm not going to know what the hell I'm talking about. So I think a little bit of fear is a good motivating factor. So here we go. We're back and we're going to start talking about shock now. What is shock? Well, whatever it is, we're going to talk about the pathogenesis of it, what it looks like morphologically, and its clinical course. And of course, if you look at the pathogenesis and you see it's both cardiac and septic and hypovolemous, you could probably figure out that shock means cardiovascular collapse. It means the failure of the blood to perfuse the entire body properly, not just kidneys, not just brain, everything. So, the common pathophysiology of shock is either there's inadequate cardiac output or inadequate blood volume. I really can't think of any other reason. You just don't have enough total body perfusion. You're in shock. Now, the results of it are inadequate tissue perfusion, cellular hypoxia at all levels, and, as you might guess, if it's uncorrected, it's fatal. You could probably think of shock as a total body infarct. You might also think of it as a total body coagulation, because hand in hand with shock often is DIC. And if you have inadequate or non-laminar flow, those endothelial cells start to go crazy, and they start to activate, and they start to form blood clots. So that's why, like we said before twice, shock and DIC go hand in hand. So if you want to actually classify shock into three types, think of it as being due to heart failure, whether it's acute or chronic, or whether it's due to an inadequate blood volume. Maybe you are showing massive hemorrhage or leaking from that blood vascular compartment. Another type of shock, which is actually probably more common than the other two types, is called endotoxic shock. And endotoxic shock is overwhelming infection. It's the #1 killer in the ICU. It's in people that are at great risk for infections or have had infections. And theoretically, a fourth and a fifth type of shock would be possible. Neurogenic shock. If you remember that vascular tone has a strong neurogenic component by the sympathetic nervous system, a loss of that tone theoretically, diffusely, might result in neurogenic shock. That's the concept. And we've also heard the term or the frequent adjective put before shock, anaphylactic shock. And if you remember, there's IgE mediated vasodilatation and increase in vascular permeability. In anaphylactic shock, you have antigens that trigger off mast cells that produce IgE, which are systemic diffuse vasodilators, and therefore they could increase that vascular permeability at all levels, and bingo, that would be the same as hypovolemic, wouldn't it? Let's start with the first one. Why would you go into shock from a cardiogenic point of view? Well, obvious, an acute MI. What about patients that have mural or infarcts involving the whole ventricular wall, and that wall weakens because of the lack of structure and texture of that tissue? Very, very commonly in acute myocardial infarcts, not instantly, but usually within a few days, that whole ventricle can rupture. That's a very, very common finding. A sudden arrhythmia resulting in non-contractility of the heart, or significantly like a fibrillation, could cause cardiogenic shock. What about if the heart is compressed from the outside, like a very significant pericardial effusion, causing cardiac tamponade, or external diffuse cardiac compression, and therefore interfering with its contractility? That's another reason for cardiogenic shock. And finally, if you remember, we told you that if you obstruct over 60% of even your pulmonary vasculature, even though it's not systemic, if you obstruct acutely over 60% of your pulmonary vasculature, that heart's going to fail acutely in a situation called acute cor pulmonale, or right heart failure acutely. And of course, if the right heart fails acutely, guess what? The left will eventually go along with it, causing systemic shock as well. What about the concepts behind hypovolemic shock? Well, in every case of hypovolemic shock, you have fluid which normally should be in the vascular compartment. Remember, we told you that 5% of all body water is in blood vessels, and the bigger compartments are the intracellular and extracellular. Well, the end result, if you take that compartment as a physical concept and it leaves the compartment, perhaps in acute hemorrhage, or perhaps through the GI tract, or perhaps through the skin with burns because of damaged blood vessels. That would be an example of hypovolemic shock. And remember, it doesn't have to be a direct departure. It could also be indirect. For example, if you took a lot of fluid in that relatively small vascular compartment and shifted it into the extracellular fluid or intercellular fluid, but not intra, then that would be a reason for shock as well. Septic shock is the third concept, and this is more of a physiologic concept. It's more of an immune concept, but it's there. You could have a normal heart, you could have normal fluid inside your blood vessels, but in overwhelming infections, what we once called, and we still do call, endotoxins, chiefly from the gram-negatives, but also from the gram-positives. Endotoxins are LPSs, that's the new buzzword, lipopolysaccharides, because that's what they are. Well, they trigger off your T cells, which activates a diffuse systemic inflammatory cytokine cascade, which once again would be like a total body infarct. And this would also be a setting for DIC as well. And remember the concept of toxic shock syndrome with staph? It was associated with tampons. Well, those super antigens technically were from the gram-positive organisms, Staph aureus. But most of the septic shock is gram-negative shock. So that's another adjective you'll often hear before the word shock, is gram-negative shock. Well, in septic shock, it's a little bit different because in the process of those super antigens causing, let's say, a diffuse body inflammatory reaction, you have significant peripheral vasodilatation, and therefore pooling, and therefore lack of flow. Okay, well, you have lack of flow, and those endothelial cells don't like lack of flow. So what do? They get activated, and they wind up causing clots, the same type of coagulation we saw with any type of a blood clot process. And it's very, very, very often and likely, if that shock lasts long enough, that it'll be coupled with something that's probably just as bad, DIC. So you can think of DIC with shock as either a total body inflammatory response or an early total body infarct. You really can't use the word infarct because infarcted tissue is dead tissue. So like an infarcted person would be a dead person. You can still have somebody in septic shock and DIC that is live, but they're usually barely alive. So the endotoxins in septic shock are usually gram-negative. They represent lipopolysaccharides from the degraded bacterial walls, and they attach to cell surfaces known as CD14, if you want to remember that. And I have a little diagram of it over here for the physiology people. The lipopolysaccharides get increased. They attach to CD14. They wind up triggering off the cascade. You remember that TNF-alpha and interleukin-1s are usually the first two big controlling cytokines, okay, and then they give rise to a whole family of other ones, and actually TNF usually occurs a little bit before interleukin-1. So there's your cascade, okay, and by the time the TNF-alpha and the interleukins are triggered off, the lipopolysaccharides are usually, almost absent from the blood. So there's a lot of overlap with these curves. Septic shock events, well, because of that total body small blood vessel response, you have systemic vasodilatation, and you remember that it is the tone of these small vessels, especially on the arterial end, that maintains blood pressure. So when that tone is gone, you have significant systemic hypotension. And now, because of a decrease in myocardial contractility and lack of blood flow, we could have activation of those endothelial cells simply because there's no flow, leukocyte adhesions to the endothelial cells, Also in the lung, there is a concept of alveolar damage, or what we call the adult respiratory distress syndrome. And the adult respiratory distress syndrome is sometimes called non-cardiogenic pulmonary edema because it's a lot of fluid within the alveoli, but remember, there's also a lot of fibrin as well. So it can be thought of as pulmonary edema in which the fluid is now a exudate rather than a transudate. There'll also be blood cells in the alveoli. There'll also be fibrin. There'll also be proteins. And here we go. The whole system then, hand in hand with DIC, progressively there's vital organ failure. You know, the last vital organ to go in your patients is central nervous system, and the most serious organ to go before that are the kidneys. So you can have what they call shock kidneys or tubular necrosis. We'll show you a picture of that as well. Here's the general clinical stages of shock. In the first phase, there are compensatory mechanisms such as release of massive catecholamines, try to keep up that tension and pressure in the blood, and sometimes it does. That's called non-progressive. It's reversible. It's not always reversible. It's frequently reversible if things are corrected properly. In the progressive stage of shock, you now have early organ failure, acidosis, okay, because of inadequate tissue perfusion. Okay, that's very, very serious, very, very often irreversible. But then there's finally an irreversible change where the patient is still alive, but there's really nothing that can be done. And I think you may have seen that personally as well. So in the non-progressive stage, you have the physiologic compensatory mechanism, release of catecholamines, but the vital organs stay perfused. In the second stage, the vital organs are at risk. There's early failure. The vital organs in this case is usually the kidney. So there's oliguria, there's acidosis because of inadequate perfusion. And finally, irreversible. Patient's alive, but you know, I know you'd like to help them, but you can't. Or major organs have failed. Brain is the last to go. You know, they're dead. So, the pathology of shock is multiple organ failure. Very often there's subendocardial hemorrhage too. If you remember, the inner part of the myocardium, or the part that faces the lumen, or subendocardial, is perfused, you know, by blood from inside the ventricle. The coronary arteries, which run along the pericardial surfaces, perfuse the entire ventricle, but they preferentially perfuse the outer portions of the myocardium. So subendocardial hemorrhage and subendocardial infarctions. In shock, the first part of the myocardium to die is the subendocardial area. We're going to be dealing with the concept in the kidneys of something called acute tubular necrosis, and there's a lot of reasons for acute tubular necrosis. Some of them are even toxic, but the unifying feature behind most acute tubular necrosis, even though toxins may be involved, is inadequate blood flow. Think of it as an early infarct. And in this early infarct, the tubules are more likely to become necrotic before the glomeruli do. That's why it's called acute tubular necrosis. You'll see normal glomeruli, and then it'll be surrounded by necrotic tubules. We talked about acute or adult respiratory distress syndrome. That's the same as DAD, by the way. This goes by a wide variety of names. And the reason why it's doing that is because the alveolar damage, endothelial damage, is reacting to inadequate perfusion and causing this total pulmonary inflammatory response, just like we talked about the shock as being like a total body inflammatory response. GI mucosa is particularly sensitive to lack of blood flow, and when you get an infarct of the GI mucosa of the bowel, whether it's from shock or an infarct or something else, the mucosal aspect is the first to become dead and winds up being hemorrhagic. So, of all the causes of GI bleeding, ischemia, shock, lack of blood flow, either regionally or diffusely, is a cause. Liver necrosis, same reason, is that we now have an acute total release of catecholamines and clotting going on within the liver as well. And we've already talked about the relationship to DIC. So sometimes when I think about it very, very, very intensely, DIC is so much tied into shock that you cannot talk about one without talking to the other. Here are our lungs. Okay? Now at first we called this ARDS, and then a couple PowerPoints later we called it DAD for diffuse alveolar damage. It's also been termed shock lung as well. But no matter what you call it, the adult, or sometimes I'll even say acute respiratory distress syndrome of adults, but that's differentiated from childhood or newborn respiratory distress syndrome, DAD, is exactly what is going on. It's a diffuse alveolar damage. You're getting the triggering off of the inflammatory process and all these septae. There's fluid leaking out into the alveoli and cells and proteins and inflammatory debris. And by the way, folks, I know you're still there. What is this purple stuff here, this granular purple stuff, you know, in the wall of this alveolum? I know you're there. Yeah, that's fibrin as well. It might look like it could be anything that's pink, but when you see something like this and you know it's a damaged lung. Another way to think of ARDS or DAD is pulmonary edema. Sometimes this is called non-cardiogenic pulmonary edema, but in this case it's an exudate in cells and proteins filling up these alveoli, not just pure transudate water like we saw with classical pulmonary edema. So what's the difference between pulmonary edema and ARDS? One's a transudate, one's an exudate. Here's something you've seen before. I think you'll recognize these as myocardial fibers. I think you can also recognize the fact that there's some early infiltration of inflammatory cells. And if you look closely, whereas most of the myocardial cells in the lower left still have pretty good nuclei, in this upper portion here, you're seeing that some of the cells have already dissolved, karyorhexis, and that occurs usually just like a few hours or perhaps one day before the neutrophils come in. So here you have necrotic myocardium, lack of perfusion. And of course, if this is somebody in shock, the earliest changes are usually subendocardial. Last but not least, or almost last but not least, here we have a kidney. I think you could recognize that instantly. I think you could see that there are nice glomeruli that look pretty normal. Even if you haven't seen a million of them, that looks normal, that looks normal. But look at the tubules between these glomeruli. Do they have nuclei? Do they have lumen? Or do they just have pink, granular, necrotic cytoplasm? Are they necrotic? Is this coagulation necrosis? Absolutely. So that's acute tubular necrosis. Also due to renal, significantly reduced renal thing. This ATN can be reversed depending on how severe it is, but you could probably think of ATN as an early total renal infarct that has involved earlier or primarily at first the tubules, relatively sparing the glomeruli. So for some reason in nature, somebody, whoever made these kidneys way back when, they decided that's more important to give blood supply to the glomeruli rather than the tubules. Here's the glomeruli, however, and in these glomeruli, you can see that there are thickened, granular, pink stuff. What do you think this is on the left over here? Well, if you don't know for sure, look we did a fibrin stain on the right. Fibrin stain stains fibrin black. So here we have diffuse deposition of fibrin in the glomeruli because of small vessel activation, and that means that this person's fibrin and perhaps platelets and other consumable factors like factor VIII are now very, very, very deficient throughout the rest of his body because they're being consumed all over these other places. Which means on the one hand, he's clotting here, but elsewhere he's bleeding because of lack of platelets. I mean, isn't this about the worst possible thing you could imagine? And finally, clinically, you're going to be witness to this. If you haven't already, you're going to be seeing patients that die. Most patients that die non-acutely die of shock. You know, the first thing they monitor in the ICU is the blood pressure. That goes down. Very shortly thereafter, there is a fast heart rate, or faster. Very likely it was increased during the hypotension period even. Finally, secondary to that, usually following the tachycardia, is the rapid breathing, or tachypnea. At first the skin is warm, then it turns to cool because of lack of blood flow there. At first it's warm simply because it's hyperemic in the small vessels. Then it becomes cyanotic, lack of oxygenized blood, renal insufficiency, obtundance, and death. I think the reason why I made this slide yellow is you should know this is a rather a linear progression, in that, for example, if your shock patient has cool skin, that's more serious than if he has warm skin. And you know that if he's already tachypneic, he's probably already tachycardic. And if he's already tachycardic, he's already hypertensive. And if he's obtundant, he's probably already had renal insufficiency. And there's only one thing left beyond that, and that's called death. Okay, we're done with this chapter, and I see we still got a few minutes left. So thank you for working very hard. I know that you all had patience to come back. I know that we are going to be looking at a few slides now. I don't know if we'll be able to see all of them. And we still got, well, let's say maybe 20 minutes to look at some slides. So take a deep breath, stretch, you know, maybe get up and get another coffee or something, and in about 20 seconds, we're going to go to lab. We're going to get off the auditorium chair, walk down the hall, follow our noses into the smelly formalin lab, open the door, sit down, you know, whip out the key to our microscope drawer, hope that nobody stole it, hope that nobody stole our slides, hope that the bulb didn't burn out, sit down, get everything focused, and now we've got some slides in front of us. And here's the first slide right here. And you know, I've labeled it. You know, I don't think that education should be a guessing game. Okay, if you want to read my little codes on the slide before you actually look at it, you can. So you pretty much already know what this is going to be. This is a real slide now. This is not a captured image. I think, oh, here, let's zoom in on this general area. You know, this is a big blood vessel. This is probably a segmental artery over here. But let's look at, you know, the middle portion of this big field. I think you could already spot out about 20 glomeruli. And once again, the glomeruli look like they are pretty much in good shape here, don't they? But what about these proximal tubules between the glomeruli? So, what's your diagnosis? Glomeruli look good, tubules look necrotic, somebody in shock. That's why I put the symbol on it, ATN, acute tubular necrosis. Okay, how would you differentiate acute tubular necrosis from a renal infarct microscopically? Well, in a renal infarct, everything is dead. Everything is coagulative necrosis. In acute tubular necrosis, it's primarily the tubules. Oh, and by the way, I'm feeling a little bit Yeah, somebody mentioned some thyroidization here because these tubules have inspissated fluid. They almost look like thyroid. And of course, you see that with pyelonephritis, but I think you might call that thyroidization. Thanks for reminding me. Last trivia question. Let's say that you're looking at a renal cortex. What percentage of the tubules that surround a glomerulus are proximal convoluted tubules? All I have to do is say very few, half, or very many. Yeah, most of them. Thanks. You got the right answer. Most of them are. The ones that have much more of a lumen, these are probably distal over here. In fact, sometimes the distal come in pretty close contact to the vascular pole of the glomerulus to become part of the juxtaglomerular apparatus. But all of these things here, all of these tubules are proximal. Okay, in fact, can I ask you another question, as long as you're on a roll over there? Let's say that you had a guess which of the tubules are more likely to be necrotic because of shock and hypoperfusion. The proximal tubules or the distal tubules? Well, in this case, we're saying it's proximal because the distal ones, there's a lot of good-looking distal ones in here, but I don't see any viable proximal ones. Okay, I don't know if that's a fact, but I bet you we could Google it and find out, and I bet you it's true. So, let's go to the next slide. Remember, these are all hemodynamic cases. Well, here's something here that looks light, here's something here that looks pink, and here's something here that looks red. So let's go to the red area first, because we're more likely to identify the tissue or the organ by looking at the area that looks... Okay, instantly, knee-jerk reflex. What tissue is this? Brain, CNS. Most of the cells are glial cells. I think I could convince you that probably this cell, some of the bigger cells, most of these are glial cells, but look, that's probably a neuron over there. The glial cells, which are small and have little halo, are oligos. This is primarily white matter, which is why we're finding a hell of a lot more glial cells than we are neurons. Okay, so this is the normal brain. Now look at this. I'm going to take my little hand over here, and rather than looking at this nice viable red area, we are now going to roll into the middle pink area. And I want to ask you a question. We did this just now, and we're going to do this area now. So here's my question. Compared to the last normal area we saw, what do you see in this area? Ha 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 ha. You're almost all wrong. Oh, somebody got it. 2 people got it. Well, what you see here is that, don't you think there are a lot more glial cells in this area compared to the other area? So remember we said non-specific brain injury, no matter what it is, whether it's an infarct or anything, is accompanied by edema, gliosis, and demyelination. Well, look, there's a hell of a lot more glial cells here, aren't they? So now, I think you could probably make a case for some edema as well, or light watery spaces within the brain tissue, but there's a gliosis here. And somebody said neutrophils. Generally speaking, in an infarct, neutrophils can come in, but it's more likely you're going to have glial cells, of which a lot of them are the microglia, because they act like macrophages in the brain. Now we're going to show you the third area. So here was the normal brain, here was the gliosis and some edema. And I think you could think already this upper part here is extremely wet, extremely liquefied, liquefactive necrosive. All you see here is edema and some residual glial cells, or if you want to call them inflammatory cells of the CNS. So what would be probably the most common reason to have liquefactive necrosis in a brain? Anything can cause it, but Really, what's the most common thing? Hypoxia, ischemia, infarct, stroke. Okay, those were the first 4 answers, and they're all correct. So, seeing as everybody is smart, let's move on to the next case. Oh, this one's not too hard either. Here's something that's pink. I don't know if you're going to recognize it right away. I'm sure some of you will figure it out pretty quick. I'm going to just zoom in on this area here and ask you, what organ is this? Yeah, you all know it's liver. Now, next question is twofold. Number 1, are these normal, hexagonally arranged lobules, or are they irregular nodules? A or B? Yeah, you got it right. Secondly, is the fibrous tissue confined just to the portal triad, or does it extend to adjacent triads? A or B? Okay, you all got it right. So this is what? If you have fibrous tissue and irregular nodules, what is the diagnosis? Next question, you all got it right. Now, here's the tricky part. So this is a patient with cirrhosis, big deal. Now, if the liver is nothing but a filter between portal blood and hepatic vein blood, do you think it would function effectively as a filter if it was all scarred up like this, or it would cause increased pressure in the portal side of the liver? So that's portal hypertension, right? Increased hydrostatic pressure in the portal vein, and therefore increased hydrostatic pressure in veins, even if they're just portal veins, is going to result in edema. So that's why people with cirrhosis get portal hypertension and ascites. Now, is there an explanation for why the patient may have edema in other places besides the portally fed organs like spleen and pancreas and bowel? Let's say that this patient's liver, when it's normal, makes albumin. And albumin is the main protein to determine oncotic pressure, or the opposite of hydrostatic pressure. Let's say this patient's liver is diseased, it's cirrhotic, so it's not making much albumin. So the patient has hypoalbuminemia. So is that going to result in reduced oncotic pressure and systemic edema? Not just portal edema. Okay, good. You got it right. You got all the concepts correctly, and you all get A's for today, especially those who didn't go away after we had our crash. Here's another real simple concept. This one, you know, I have to show it because we talked about it. Let's say that you don't even care what organ this is, but you could see these diffuse infiltrates of red blotches. You want to call this acute, chronic, or old hemorrhage? Okay, let's say instead of red blotches, there were a lot of blood vessels growing within these red blotches. Would you call that acute, organizing, or old? Let's say rather than red blotches or a lot of blood vessels with them, there was all scar. Would you call that acute, chronic, or old? Okay, and by the way, do you know what the organ is, or do you want me to zoom in a little bit so you could see? You could probably take a guess. Oh yeah, a couple of you are getting it right. Most of you are getting it right. Somebody said heart. I can believe you. Most of you are saying brain. But here, let's settle the argument and go to an area where there's not much hemorrhage. So what is this? Now you all know it's brain, right? Almost all of those are oligos. You can see some blood vessels. It's probably an area of white matter. I don't know if I could find too many really convincing neurons. But it's acute hemorrhage in a brain. Now, if some of the strokes are caused by brain infarcts because of thrombosed vessels, what if those vessels rupture, the walls rupture, like a ruptured aneurysm or a ruptured blood vessel that's weakened by atherosclerosis? What if the vessels rupture, the vessel walls rupture, rather than are thrombosed? then will your infarct be hemorrhage, or will it just look like liquefactive necrosis? Yeah. So this is a hemorrhagic infarct. Are most of the infarcts of the brain hemorrhagic or non-hemorrhagic? I think most of them are non. But if you rupture a large cerebral blood vessel and it dissects into the brain, it'll be hemorrhagic. If that hemorrhagic infarct that we see here was caused by a ruptured middle cerebral artery, or anterior or posterior or whatever, where do you think a lot of blood would collect in this person's brain? Epidural, subdural, or subarachnoid? Yeah, subarachnoid. Most of you got it right, because that's where the big vessels run. Okay, we got a couple more slides, I think. Oh, here's kind of a nice one. I already showed you recent infarcts. You're kind of sick of those. Here's a piece of tissue. It's pink. Oh, I think you can see what is probably already there, mostly a blood clot. You can see some fat. You can see a little fibrous membrane here. And in about 3 seconds, as soon as I zoom in over here, right underneath the fat, you'll see that these are chiefly cardiac muscle cells, right? And there's epicardial fat. And then here is the visceral pericardium. And yeah, there's some inflammatory cells around it. And there's a little nerve there, isn't there? And there's some of your pericardial fat in which the large blood coronary arteries run. But we are digressing. The thing that we want to see, and this is a beautiful case, I'm going to tell you why it's a beautiful case, is I'm going to zoom in on this middle area. Now, the top area is pure blood clot. The bottom area is infarcted myocardium. And you must get this question right, because if you don't, I'm going to feel like I failed the entire day. And here's the question. Do the same exact changes of acute organizing old in a blood clot follow the same general evolution of changes in the tissue in which they infarct? Acute organizing and old. That's the main point. Yeah, the answer is yes. And, you know, everybody got it right. In fact, you want to know something? You could still see some myocardial fibers here, but you can't see them here. But you could have, very often when we look at a heart that has a mural thrombus, it's very hard to say where the clot ends and where the myocardium begins, depending on the sequence of these changes. But in this case, we're lucky enough to have a nice little cleft or a separation. So there's the blood clot, and there's the infarct. And here, I'm going to ask you one last question. I'm going to zoom in this area here in Connecticut. Is this part of the blood clot more recent, and is this part of the blood clot more organizing? Look at all these vessels. You would say this is probably an organizing blood clot, right? But what if the whole blood clot looked like this here in the Northwest? Would you be more likely to call it acute or recent? Yeah. But if you were only looking at, so if you want to diagnose this correctly, could you say that maybe this was an organizing blood clot that also has a recent component to it as well? That's probably the most honest diagnosis. Okay, we're done with that case. You're going to love this, because this is going to be what a lot of your patients die from, especially if they're chronically debilitated, and all those other reasons for emboli. You could instantly recognize this as lung, right? That one we don't have to zoom in on. Here's a large pulmonary artery vessel. Maybe it's a main vessel going to a segment or even a lobe, but most likely, because it's surrounded by lung, it's a segmental vessel. Okay, so this is what you have to do. Let's say there's $1 million lawsuit going on here, and they're going to sue the hospital for, bad surgery. And now you're the pathologist, expert witness, and you know this is lung, and you know these are some alveoli out here. You know this is a pretty thick pulmonary artery wall, and you're looking at the blood on the inside of it. Okay, nobody is allowed to get this question wrong. Is this blood clot pre-mortem or post-mortem? And you're all getting the right answer. You're all saying pre. Yeah, I think there's a case here for these being lines of Zahn. You have cells, you have fibrin, they alternate a little bit. But can you see how there's an adherence? There's no way in the world you could ever imagine sticking a little forceps inside that artery and easily taking out that clot. It's adherent also, isn't it? So don't forget, if you call this pre or post-mortem, you know, first of all, if it's post-mortem, it probably didn't kill the patient. If it's pre-mortem, it may very well have been what killed the patient. So it's of tremendous medical legal significance. And we're done with that case. We'll take one more. I think we'll do this one. You probably don't know what it is. In fact, I dare you to guess what this organ is right now. You'll never know. Well, you know it's something. And here, I'm gonna zoom in this area here, the top to middle portion. Do you see the little box that I'm making now, which includes the top and the most of the middle? On the top, it almost looks like nervous tissue, doesn't it? In the middle, you have a few little follicles here that look like thyroid. In the bottom, it may be coagulative necrosis, but I think you can still recognize the fact that it's basically glandular. Okay? So does that look like nervous tissue to you? That's posterior pituitary. That's neurohypophysis. Do you see these things that look like glands? And not only are they glands, but they're red glands. So they are probably predominantly acetophils. And do you remember what the intermediate lobe of the pituitary looks like? It's one of the few things that still looks like there's a few thyroid follicles. So, here's the first question. Do these cells, well, you can see nuclei, but sometimes the nuclei are hard to see. Can I make a case for coagulative necrosis here? Okay, well look, if you're not convinced, I'm going to take the bottom part. You see this blue stuff over here? You think, oh, are these lymphocytes inflaming the pituitary? They're really blue cells. Guess what? Those are basophils. Here's probably some acetophils up here, but for some reason, a little collection of basophils is right here under the capsule of the adenohypophysis. Now, do you see how in this area you could see nuclei of cells, but on the bottom, but up here you could very, very hard to appreciate nuclei. So you have coagulative necrosis in the pituitary. Well, if it was a heart, you call it an infarct. If it was a spleen, you call it an infarct. If it was a kidney, you call it an infarct, causing all of that coagulative necrosis. But it's in the pituitary. So what do you want to diagnose this as? Pituitary infarct. Okay. And in this area, you can see there's still a lot of viability of the basophilic cells. And up here, I don't know, maybe these were acetophils, but there's a lot of necrosis. So is it a complete infarct, or you think it's a partial infarct? A couple of people have already said Sheehan syndrome, and I'm thinking it could be. It could be, because you can get infarcted and hemorrhagic pituitary following delivery of Sheehan syndrome. But let's make things simple. What is your final diagnosis for the final case? Keep it simple, because the simpler you keep it, the more likely you are to be right. Most of you are saying partial infarcts. Some of you are, a couple of people saying complete. And I don't blame the person that's complete, but if it was complete, the whole thing would probably show lack of viable cells. So that's why the partial people are probably more likely to be correct. And we're done with lab. We are done with chapter 4, hemodynamic disorders. And next week, in exactly 5 days minus 2 hours, we'll start with genetic disorders. So I think we're ready to play our final song. And I want to thank Dr. Kamat again for answering all those questions, because I would actually be going crazy if I would try to type in the chat to all those questions and speak at the same time. I mean, I could multitask, but that's something that's beyond my capabilities. So thank you, Dr. Kamat. Thank you for those of you that came back after the mid-explosion, and we'll see you next week. And rock on. Here's the last song by Eric Clapton. The most beautiful song. Rock on, you buzzards, and yes, you were wonderful tonight.